Breathing exercises. Breathing exercises to increase lung volume should be performed in cycles of no more than 3 or 4 breaths so that maximal effort is put into each breath, dizziness from overbreathing is avoided, shoulder tension is discouraged. Once inflated, alveoli stay open for about an hour at normal tidal breaths, so it is advisable to do at least 10 deep breaths every waking hour to maintain lung volume. This is a tall order for those who are distracted by the events and uncertainties of hospital life, and patients can use reminders such as food and drink trolleys or nurses' hourly observations. Deep breathing. Optimum conditions are needed to ensure that deep breaths reach peripheral regions. The following will facilitate this: relief of pain, nausea, dry mouth, discomfort, fatigue, anxiety, or tension, avoidance of distractions, minimum breathlessness. Example, patients need time to get their breath back after turning. Accurate positioning, usually side lying, inclined towards prone to facilitate maximum expansion of the base of the uppermost lung. If side lying is impossible, upright sitting is the next option. Long sitting may be necessary in some circumstances, but allows limited expansion only. Leaning forward, long sitting is useless for increasing lung volume because the diaphragm is compressed up into the chest, even though the thorax may be expanding. The effectiveness of the side lying inclined towards prone position can be confirmed by auscultation. When ready, patients are asked to breathe in deeply and slowly through the nose, then sigh out through the mouth. A demonstration is often the best way of explaining an action that is normally automatic. Breathing through the nose warms and humidifies the air but doubles resistance to airflow, and patients may prefer to mouth breath if they are breathless or have a nasogastric tube. Some respond better when asked to take a long breath rather than a deep breath, or when asked to breathe in your favorite smell. Distribution of ventilation is related to position, flow, and pathology. The physiotherapist's hands may be placed over the basal area for monitoring purposes and for patient reassurance, but not with any assumption that this magically redistributes ventilation to the underlying lung. Localized breathing exercise do not make physiological sense because humans are unable to deform individual portions of the chest wall, but patients can still be found obediently performing unilateral breathing and basal coastal breathing. Even if localized breathing were physically possible, as in some yoga masters, the way in which the two layers of pleura slide on each other means that the lung responds generally rather than locally to a deep breath. After every few breaths, the patient should relax and regain his or her rhythm. Breathing rate and pattern should be observed at this time, and the patient may need praise or a change in instruction before proceeding. Sometimes patients are more relaxed and breathe more effectively between a cycle of breaths than during the deep breathing itself, in which case attention should be paid to minimizing tension during the next cycle. Patients should not be engaged in conversation between cycles. Deep breathing has shown the following benefits: increases lung volume, increases ventilation and decreases airway resistance, increases surfactant secretion, thereby improving lung compliance, improves VAQ matching, decreases dead space ratio, increases diffusion, increases oxygen saturation. With slow breathing, improved basal ventilation as a result of reduced airway turbulence and preferential distribution of air to dependent regions. Shallow breathing is inefficient because more tidal volume is lost to dead space as the same air is inhaled and exhaled more often. Breathless people require a special approach and should not be asked to breathe slowly. The term thoracic expansion exercises is synonymous with deep breathing. Thoracic expansion can be readily observed but does not guarantee a deep breath. Literal interpretation of the terminology or the patient's position may inhibit the most subtle abdominal excursion. End inspiratory hold. Air can be coaxed into poorly ventilated regions by interspersing every few deep breaths with breath holds for a few seconds at full inspiration. This distributes air more evenly between lung segments and boosts collateral ventilation. Ideally, inflating pressures of 30 to 50 cm H2O should be held for 5 seconds at 2 to 6 times tidal volume. But many postoperative patients cannot achieve this. Observation will identify if the end expiratory hold is effective, comfortable, or conversely disturbs the breathing pattern. Accurate instruction is needed to prevent shoulder girdle tension. The end inspiratory hold is unsuitable for breathless people who should not be asked to hold their breath. It should be used with caution in patients with a tendency to bronchospasm. Abdominal breathing. Emphasis on abdominal movement during inspiration leads to slower, deeper breathing, less turbulence, reduced dead space, and shoulder girdle relaxation. The term diaphragmatic breathing is sometimes understood by patients, although abdominal movement does not ensure greater diaphragmatic contribution to breathing. The term breathing control is synonymous with abdominal breathing at tidal volume. The patient is asked to get comfortable in a symmetrical position such as upright sitting. The maneuver is first explained and demonstrated unhurriedly, avoiding words like push, pull, try, and harder. If relaxed abdominal breathing has not started naturally, then the patient is taken through the following steps. Rest the dominant hand on your abdomen with elbows supported and keeping your shoulders relaxed. Allow your hand to rise gently while visualizing air filling your abdomen like a balloon. Sigh the air out. Check that shoulders remain relaxed and heavy. Gradually increase the depth of breathing while maintaining relaxation. If appropriate, progress to side lying and relaxed standing. Many patients respond to the physiotherapist's hand placed on the lower abdomen to encourage breathing in and down. Variations include putting the other hand on the quiet upper chest to compare it with movement of the abdomen, reminding patients that when filling a kettle, they don't fill the top half first. Imagining a piece of elastic around the waist stretching during inhalation. If supine, placing a box of tissues on the abdomen to visually reinforce the movement. Incorporating incentive spirometry to encourage a slow flow rate, give feedback on the larger volume inhaled. Some non-surgical patients find that other positions facilitate abdominal movement, example prone lying, 4-point kneeling or standing with hands on back of the hips and elbows pushed backwards. Abdominal breathing usually increases the lung volume but is not thought to alter the distribution of ventilation. However, the slow, deep breathing it incorporates favors peripheral distribution. Sniff. Even after a full inspiration, it is often possible to squeeze in a wee bit more air and further augment collateral ventilation by taking a sharp sniff at end inspiration. Skeptical patients can be won over by a reminder that however packed a rush hour underground train is, an extra person can always be crammed in.